Good evening, everyone. Welcome to tonight's webinar. My name is Dan Green. I will be your host. You lucky guys, you're going to have me for 2 full hours. So first of all, I want to apologize for last Tuesday and not being able to be on the webinar, and I thank you guys for arranging your schedules such that you're able to join us tonight a little bit early to kind of make up for last Tuesday. So again, please accept my apologies for missing again. Tonight is Sunday night, and last Tuesday, of course, being a Tuesday, both nights would be case list review night. So we will be taking folks, we will be going over people's lists. What I will ask is if you've had an opportunity to be in the hot seat, let's say last Wednesday, that you not volunteer at first, so we have an opportunity to let some other people be in the hot seat. If we get no volunteers, by all means, I'll be happy to take anybody that wants to go in the hot seat. So having said that, why don't we get started? And I'm assuming you guys can all hear me. Okay, so Aaron, great. Were you volunteering, or I saw the hand go up and go down? Yep, okay. I'm taking you off mute, Aaron, if you can. There you go.
Yeah, can you hear me?
I can hear you now, yes, thank you. So, Aaron, are you a generalist or a specialist?
I'm in my GYN oncology fellowship.
Okay. Well, you know what we're going to do for you then, right?
Probably not GYN, and that's fine. That's where I need the help.
Yeah, probably not GYN. So, I think we will do, why don't we do patient number 4? Hopefully you'll be able to see my list, or you can see it. Are you able to see it at all?
Yep, I can see it.
Okay, so just for everybody to make sure everyone's able to see the list, patient 4 is a 29-year-old G2P0 39-1 whose breech had no delivery complications, had a primary C-section. The baby weighed 30/60 with 7 and 8 APGARs. So, Aaron, do you offer patients external cephalic version?
Yep, an external cephalic version definitely could be offered to a patient who is a candidate and is interested in attempting one to achieve a vaginal delivery.
Okay. What gestational age do you do your versions?
I would do an external cephalic version at 37 weeks.
Okay. So what about if a patient, what about if this patient had said to you, hey doc, you know, not really interested in a version, but I would like to try a vaginal breech delivery. Is that an acceptable option for her?
I would say oftentimes it's not something I would recommend or consider acceptable, since we know that the risk of neonatal outcomes and morbidity can be higher in the setting of a breech vaginal delivery, especially with the risk of head entrapment and asphyxia as compared to a primary cesarean delivery for a breech presenting fetus.
So you said head entrapment. What's meant by head entrapment?
Head entrapment would be at the point in which during a breech vaginal delivery, the body has delivered and the head is stuck above the external cervical os and in the lower uterine segment, and the uterus is potentially contracting in a way that is not allowing the head to be delivered. So the umbilical cord and fetus trying to breathe naturally are unable to, and you worry about a prolonged period of time of head entrapment leading to.
So what would be, I'm sorry, what conditions would predispose a patient to having a head entrapment? So what are risk factors for head entrapment?
Certainly a nulliparous patient, you would be worried about head entrapment since this is their first delivery. That's something I would consider on the maternal side. On the fetal side, if the baby has any sort of anomaly, so hydrocephaly or macrocephaly, then I would certainly be concerned about head entrapment as well. Or any, I guess, back to the maternal side, if there were any sort of obstructing causes like a lower uterine segment fibroid or mainly a lower uterine segment fibroid, then I would certainly be worried that the birth canal is not going to be adequate for delivery of the fetal head.
Okay. So in talking to that patient about an elective vaginal breech delivery, so again, allowing her to labor and attempt a vaginal breech delivery, I understand that you wouldn't do it, but is it an acceptable option for patients?
I think in certain circumstances, it could certainly be discussed, but I think in a nulliparous 29-year-old patient, I don't think it would be acceptable to discuss. I think the neonatal risks outweigh the benefit of a vaginal delivery.
Okay. What are favorable prognostic factors for a successful vaginal breech delivery?
Favorable prognostic factors would include a multiparous patient, someone who's had vaginal deliveries before, someone whose baby is not macrosomic, so not above like 4,000 grams by estimated fetal weight, a baby without a congenital anomaly involving the head, so like macrocephaly or hydrocephaly, like I mentioned before, and like a normal biparietal diameter and head circumference on sonography prenatally. I would say those are the first things that come to mind. I'm sure there's other things that may make a patient a better candidate for a breech vaginal delivery, though. Certainly, if she presented fully dilated, then.
I'm sorry?
Certainly, if she presented in spontaneous labor and fully dilated, then that would increase her success rate.
Okay. Last question. Since you mentioned head entrapment before, if you had a patient that came in delivering breech, let's say the 32 weeks, delivering breech, and the baby's delivered up to the chest, so the nurse calls you urgently and you deliver the arms and shoulders, but you discover a head entrapment. What would you do?
So I would just have the patient stop pushing for a second, make sure I repeat an exam and feel for sort of any anomalies or see sort of what's causing the entrapment to begin with. And then I would certainly see if on a reattempt of push, if there's with the Moriso smelly bite maneuver where I place my second and fourth finger over the fetal maxilla, if there's an opportunity to flex the head more to allow that diameter to pass through the cervical canal, then that could certainly be a first maneuver to try. Piper's forceps can sometimes be used to help guide the fetal body downward. Also, so all of these are geared towards sort of getting the fetal head to flex more to allow it to pass. I'm
sorry, Aaron. You said that head entrapment was the head had not cleared the cervix, and it was still in the lower segment. Did you not?
Yes, previously.
Okay, so how are you going to get your hand up into the cervix around the head to do a more so smelly bite maneuver if the cervix is contracted around the neck?
If it's that contracted, then I would consider Durson's incisions at the 2, 6, and 10 o'clock along the cervix to allow the cervix to relax and open more. If I needed.
You also go ahead.
No, that's all.
You also mentioned that you were going to use Piper forceps to guide the body. Is that what I heard you say?
Yeah, they'd be placed around the fetal body.
You put Piper forceps on the body?
Sorry, they're around, the forceps themselves are around the head, but the fetus is laying on one of them. They're sort of sandwiching the fetal body, but they're around the fetal head. Sorry, I didn't explain that clearly.
Okay. All right. I think we will stop here and go over it.
Sure.
So let's see. So vaginal breech is an acceptable option for patients. I'm not saying that I would do one or you should do one or whatever, even if you weren't an oncologist and a generalist. I'm not saying we should electively do them, but there are some people in certain communities, meaning clinicians, doing them. Obviously, they're usually going to be MFMs. So, I think it's certainly reasonable to explain to the patient there's, increased risks associated with it, but it's not, several years ago, ACOG came out saying it's okay, in a properly trained clinician, and obviously we're looking for good patient selection. So not saying you should offer it to do it yourself, but, if you have an MFM and you're in a, pretty urban area, an MFM that does do them, it's not out of unheard of or anything like that. So
I was taken aback with acceptable in that scenario specifically because I know they're done.
I'm sorry, say it again.
I was thrown off by the use of the word acceptable. So I felt more secure going more conservative and saying it was not, even though in my head I know that what you just explained made sense, but I got nervous sort of saying yes, it's
right.
acceptable.
Well,
in an example.
I understand, Aaron, but it's one thing to say it's acceptable, but I wouldn't do it. Electively. It's another thing to say it's not an option for the patient, because again, if there were someone in your institution that does feel comfortable doing it, again, in properly selected patients, you've let your either bias or limitations affect what would otherwise be an acceptable option, albeit maybe not one you'd recommend for your wife or your sister, but, an option all the same that is a legitimate option. You've made the decision for the patient. Does that make sense?
Yeah, that makes sense.
Okay. So, one of the reasons you said is because of head entrapment. So unlikely, then I asked you risk factors for head entrapment. You said nulliparous patient. So that's not really a risk factor for head entrapment. That would be something that would be a less favorable or poor prognostic factor for successful vaginal breech, but it's not an increased risk for head entrapment. You did mention intracranial abnormality, so basically hydrocephaly or macrocephalic. You're absolutely right. That would be a risk for head entrapment. And then I asked you what a couple others. And so a preterm delivery patient would be at risk for head entrapment,
okay.
Because the head is going to be bigger than the body.
Yeah.
And also, if somebody had severe asymmetric fetal growth restriction, they too would be at increased risk. You could also have a discordant twins, could be a risk as well.
Okay.
Okay, so favorable prognostic factors for successful vaginal breech. You said previous vaginal delivery, that's correct. Not more than 4,000 grams. So yeah, between 2,500 and 4,000 grams, because you don't want too small a baby either, because of what we kind of talked about before with the head entrapment.
Yep.
Ideally, the patient would be 37 to 40 weeks.
Okay.
No congenital anomalies of the head, of course, as you mentioned. The other thing is, ideally, the patient would be in the frank breech presentation. would be a frank breech presentation. So, but it could be a complete breech. It just couldn't be a foot-link breech. That would be a contraindication.
Yes.
Now, you mentioned, so I asked you then about head entrapment. What would you do? If you have a baby that, if the head's not coming out, you need to do a vaginal exam and determine why it's not coming out. Has the head cleared the cervix and is in the vagina, but it's extended too far and we need to flex it forward? Or is the cervix contracted around the neck, for example, you know, in the case of hydrocephaly or preterm delivery or severe asymmetric growth restriction? If we feel the cervix, that's a whole different algorithm as compared to if the head has cleared the cervix. So if the head, I mean, we're not going to be able to do a more so smelly bite maneuver if the head's still in the cervix. So the cervix is, let's say, around the neck. Nor would we be able to do Piper forceps or anything like that. What we would do is try to give the patient a uterine relaxant, like maybe terbutaline, and see if we can reduce the cervix at that point. If that doesn't work, then you're right. The Durson's incisions would be next, and that would be traditionally 10, 2, and 6, although most would suggest cutting 2 positions and seeing if that's adequate, and then if not, cutting the 3rd.
That makes sense.
Okay. If you don't feel the head, you know, the head has cleared the cervix, then we would try that more so smelly bite maneuver to try to flex the head forward, get the occiput from around the pubic bone. And if that doesn't work, you know, you could always go to the Piper forceps. And of course, the Piper forceps are being applied to the head, and we're going to use a J motion. We're not going to pull straight out. We're going to flip our wrists forward, so almost like you're casting a fishing line, to get the head forward. So it's a short downward and a long upward pull, like a J.
That makes sense.
Any questions?
No, that was good.
Great. Thank you for volunteering. Appreciate it.
Of course. Thanks for picking something off my OB list.
My pleasure. Okay, so next up, please. Again, somebody who preferably hasn't been in the hot seat recently. Serene, how about you? Is yourself muted?
Yes, hi.
There you are. Hi, how are you?
I'm good, how are you?
Doing well, thanks. And you're a generalist, correct?
Correct.
Okie doke. And we have your list. So we will go to office. All right, let's see what we got here. Give me 1 second. Okay, patient number, oh geez, there's 2. Sorry, give me 1 more second. I'm toying between 2 different cases.
Okay.
Patient number 8 is a 26-year-old nulliparous patient who came in for a well woman visit. You did age-appropriate screening and counseling, and part of what you recommended was the HPV vaccine.
Yes.
So tell me, what are contraindications to the HPV vaccine?
Contraindications to the HPV vaccine would be pregnancy, or I think really that's the only contraindication. I can't think of it.
Okay. So which other vaccinations would you recommend for a patient, or at least want to check on for a patient who's 26?
I would want to make sure that she's had her tetanus vaccines. I would make sure that she has her vaccines for the flu, COVID. I would Want to make sure she has her pneumococ. No, not that one. I can't think of the others.
All right, so I just want to make sure I heard you because my phone is slightly going in and out. You said you said obviously the HPV. You said tetanus and COVID. Did I miss one?
Influenza.
Okay.
I can't think of any others.
Okay. So first of all, how often would you recommend the patient get a tetanus booster?
Every 10 years.
What about if she had an at-risk injury? So she steps on a rusty nail.
Then if she isn't up to date on them, then she should get the booster.
So when you say if she's not up to date, so you mean if it's been 10 years or more, she should get the booster?
Yes.
Okay. So now let's change the scenario slightly. Same age patient, but in addition to coming in for a well woman visit, her other, I don't want to say complaint, but what other issue is she wants to start a family with her partner. So would that affect your vaccination or immunization treatment?
In terms of the HPV vaccine, is that the question?
No, in terms of other vaccinations that you would consider giving or checking or what have you.
So if she was planning on pregnancy in the near future, I wouldn't necessarily start, first of all, the HPV vaccine series, as I mean, she'd continue that after her pregnancy. I wouldn't recommend the MMR vaccine right away, as she should probably wait a month before she conceives. But if her family planning was going to be further out than that, then those would be okay.
Okay, I'm sorry. I think I have a bad connection, but I'm worried if I hang up on you guys and dial in again that I'm going to end the whole webinar. So you said, I heard MMR. And did you say something in addition to it?
I wouldn't necessarily start the HPV vaccine series at that time if she was planning pregnancy in the near future, as I would have to hold off on finishing the series after she got pregnant. And then the same if she wasn't up to date on varicella, for example. Again, I would encourage her to not conceive at least a month after those vaccines.
So you said this. So you would not recommend giving her the MMR and the varicella, you said, because
if she was planning on conceiving like that month or the next month, like I would ask her, when is she planning on attempting to conceive?
Okay, so let's say she's going to start right away, so to speak, or with her next cycle or whatever. She could or couldn't get the varicella and MMR if she needed it.
I would prefer for her to hold off on conceiving after a month. So if she was going to hold off at least a month, then she could get it.
Okay, so if she's going to not try for a month, she could get it. But if she is going to try, then you wouldn't give it to her. You'd wait till after pregnancy?
Yes.
Okay. What if she, said, okay, I'm going to wait, and her husband takes her on some like whirlwind trip and whatever, and she happens to get pregnant 2 weeks after the shot? How would you counsel her?
I would counsel her that likely, the effect is not, there's not a lot of studies done on that. However, to my knowledge, I think there are research studies that she could enroll herself in just to follow up. And I would also likely get an MFM consult as well, but that's what I would tell her.
Not a lot of studies that show what?
That there are like the risks to the fetus if she got the shot.
Okay. I think that's it. Let's talk about this one. So nice job. So contraindications to the HPV vaccine. So you mentioned pregnancy, which of course is correct. Patients younger than 9, older than 45 would be contraindications, at least relative, strong relative contraindications. Severe yeast allergy would be another contraindication. And a patient with a history of Guillain-Barré in the past would be still another contraindication.
Okay.
You mentioned tetanus, COVID, and flu for a 26-year-old, all of which are correct. The flu is every 10 years, as you said. However, if a patient has an at-risk injury, the recommendation is for her to receive a booster if it's been more than 5 years since her last vaccination.
Okay.
You still with me?
Yes, I am.
Okay. So if she's planning pregnancy, as you mentioned, the key thing to find out is she immune to rubella and varicella? And if she's not, you would want to vaccinate her. Now, the varicella is going to be 2 shots. But the key thing is, as you said, you would advise her to wait for a month. If she did get pregnant in under a month, it's a theoretical risk. There's never been shown to be a case of congenital rubella or varicella from a vaccination. So I'd be careful about mentioning, though, from a technique standpoint, Serene, I'd be careful about mentioning studies because they're going to, they could certainly then start to ask you about the studies. And,
Okay.
You may not feel comfortable discussing them. You may not even be aware of them. I mean, I'm not, but that doesn't mean you're not. It's just, kind of throwing that out there.
I'm not either. I'll use the word theoretical next time.
Yeah, I mean, I would just say, there's no information or there's, no, in theory, it's a theoretical risk, but not aware of any information that, there've been reported cases, people having problems. The consultation with the MFM could go either way. It's fine if you do, it's fine if you don't. And I think that's it. Any questions?
Okay, thank you. No.
My pleasure. Okay, thank you.
Yeah.
All right. Thanks. Carolyn, I see your hand is up. Are you volunteering? Carolyn? It says you're self-muted. You have to take yourself off mute. There you go.
Can you hear me now?
I can hear you now.
Okay,
are you
great.
volunteering?
Yes.
Okay. Are you a generalist or specialist?
I'm in MFM fellowship.
Oh, okay. How perfect, because we're due for a GYN case. How did you know that was
Yes.
going to happen, huh? Okay, give me a second. And oh, by the way, everybody, we will pause at 8:20. I'll go to the question box if people have questions about any of the cases we did up to that point. We'll take those questions and then we'll move on with kind of the next set of questions. And then we'll, of course, stop at 9:20 to give people an opportunity to ask for the second hour, any cases for the second hour. And there's no rhyme or reason. If you think of something in the second hour that regarding the first hour's cases, of course you can ask it then. Okay. All right, patient number 1 had abdominal distension. She had a CT showed large bilateral cystic masses as well as fibroids. Her tumor markers were normal. We did an XLAP THBSO with an omental biopsy and cystadenofibroma, 24 and 11 centimeters. So that saves me having to ask you how big they were, but you have tumor markers normal. So what tumor markers did you get in this case?
So we would have gotten ca125, CEA, and ca199.
Okay. What type of malignancy produces, obviously ovarian, but what type of malignancy produces ca125?
That can be, like you said, ovarian or fallopian tube, also peritoneal, colon cancer, really anything that would irritate the peritoneal cavity.
So you said ovary, fallopian, colon cancer, peritoneal, but I guess my question is a little bit more specific. What type of ovarian cancer?
That would be serous ovarian cancer.
Okay. What about CEA? What are you looking for? I mean, what type of cancers, and then specifically regarding ovarian cancer, what would you be screening for?
CEA can be a marker for certain types of GI malignancy. I will have to look up what type of ovarian cancer it is specific for.
Okay. I mean, is it elevated in patients with ovarian cancer?
I don't think so.
So why would someone get a CEA then if you're, if you're looking for possibility of ovarian cancer?
I will have to read more about this topic.
Okay. Any idea about ca199?
This can be elevated in patients with ovarian cancer, I think, but I'm not familiar with which type. But I previously thought of this as also elevated in GI malignancies or pancreatic.
Okay. So what's the purpose of getting the tumor markers then? I mean, if GI cancer or pancreatic cancer, ovarian cancer could cause it to be elevated, I mean, how's this helping you when you are, what's the point of obtaining the tumor markers in the first place? Weren't you going to take out these masses?
Well, it can help guide surgical planning and patient counseling ahead of time. So with regards to surgical planning, if there was a higher suspicion for a malignancy based on elevated tumor markers, then she would more likely get a staging procedure as opposed to simply removing the masses.
Well, yeah, I know, but if it's elevated, it doesn't mean she has cancer, does it?
No, but just in terms of managing her expectations, and so when we did the frozen, the patient wouldn't be totally caught off guard postoperatively.
I mean, even if your tumor markers were normal, wouldn't you counsel the patient? I mean, why remove them then? I mean, didn't you think that she had a chance that these were malignant, independent of the tumor markers? I guess where I'm going with this is, Carolyn, if you get the tumor markers and they're elevated, it doesn't necessarily, she may have cancer, but it may not even be ovarian cancer, in which case you may be calling in a GI oncologist, number one. Number two, even if they're normal, it doesn't mean she doesn't have cancer. So I guess how is, I'm sure in your counseling you said to the patient, look, this could be malignant. We might have to do a staging procedure. Again, almost independent of the tumor markers, obviously, unless they're in the thousands, for example, or something, super, super high. Is that correct?
Yes.
Okay, so then again, why bother doing them? I mean, what's the purpose of tumor markers in these cancers?
The value is to help risk stratify patients, and also establish a baseline.
A baseline for what?
For the level of tumor markers in case they may need to be trended if the patient did have a malignancy.
Okay. Now, again, I guess in this particular case, I'm kind of scratching my head a little bit because you got the tumor markers, but you already had oncology present, or at least on standby. So again, I get it if you were out in the middle of, a very rural area and didn't have an oncologist, but you did. So how did that change your management?
I'm not sure that it did.
Okay. All right. So I kind of painted you into a corner here a little bit. Sorry about that. But, but I did it a little bit for you and for everybody to show you guys, technique if you get into a particularly awkward or tough, kind of almost a no-win kind of answer situation. And don't misunderstand me, Carol, and you by no means are the only person to have tumor markers, especially for these large bilateral masses in a menopausal or perimenopausal patient. I would have done the exact same thing you did. So I'm not questioning your care. And I know they were residency cases to boot, so you didn't have complete autonomy with it. But if they put you in a situation like that, at least in this specific topic, the key thing is, well, it really didn't change my management. I think, and you pointed out, it may help you a little bit with counseling. It didn't change my management. It didn't guarantee she didn't have cancer, nor did it commit that she definitely had cancer. However, in the event the patient had cancer, I have a baseline from which to follow the patient in terms of her response to the surgery and any adjuvant treatment she may need. Then they might say, well, why'd you get them ahead of time? Couldn't you have gotten them after the fact? Which you would say, I most definitely could have gotten them after the fact. However, the patient was, naturally anxious. And so we wanted to give her every bit of information we could ahead of time, realizing that, again, these tumor markers are not diagnostic of cancer, and explaining that to the patient. Does that sound reasonable?
Yep, makes sense.
Okay. Where it really gets to be a problem, though, is when people have tumor markers for really small cysts. It's a little bit harder to defend unless they're practicing in a rural situation. So let's go over the tumor markers. So you correctly told me that ca125 would be produced by serouscystadenocarcinoma of the ovary. Typically, it could be peritoneal cancer, certainly could be fallopian tube cancer as well. What non-cancerous conditions can cause an elevation in ca125?
Things like endometriosis, appendicitis, inflammatory bowel disease,
Okay.
Like I said,
So
anything that can kind of irritate the peritoneum.
Exactly. Very good. That's exactly right. So anything that is going to cause peritoneal irritation or inflammation can cause an elevation in ca125. What about CEA? You mentioned GI. That's correct. Any ovarian tumors can be increased by, or can increase CEA?
CA can be elevated with mucinous ovarian tumors.
Right. And that's true also of ca129. Both can be elevated with mucinous cystadenocarcinomas. CA also can be elevated in colon cancer. Again, there's your GI that you mentioned. ca129 also, and you said this, pancreatic cancer can cause an elevation in ca129. So of the tumor markers, that's the that would cover it. Just out of curiosity, you haven't listed pelvic washings here. Did you do washings when you opened this patient?
We did washings, yes.
Okay. Did you do it with the oncologist, this surgery?
Yes.
I'm sorry, I didn't hear you if you answered.
Yeah. Yes. Yes, this was
Okay.
performed with the oncologist.
Okay, so this is a GYN oncology case from residency. Very good. Any questions, Carolyn?
No, that was good. Thank you.
Thank you. Thanks for volunteering. Sorry if I was hard on you.
No, it was good. Thank you.
Great. Thank you. Okay, let's take another person. We'll do another case. Go ahead.
Can I ask one question actually? When I don't know the answer, was my answer appropriate to just say I don't know?
Well, so yeah, that's a great question. Actually, seriously, I'm glad you asked it. So it's highly unlikely they're going to ask you something you know absolutely zero about. So if there's anything that you can say that's correct about the question, I would tell them what I know. So if they said which type of malignancy, well, you did it basically. I don't have to make it up. You did it. When I asked you what type of malignancy ca125 is associated with, you said, I asked you what type of ovarian malignancy. You weren't really sure, but, you said, well, but I do know it can be elevated in, ovarian, fallopian tube, and peritoneal cancer. So again, it's not telling me specifically which type of ovarian malignancy, but you are giving me correct information about it. Now, the information has to be relevant. Or, if you'd said, I'm not sure, but I know it can be elevated in ovarian cancer and even in non-cancerous conditions. Again, it has to be relevant. If I asked you about White's classification of diabetes and you said, I have no idea, but a hemoglobin A1C gives you a 90-day look back, that would be too far asunder to mention. It's not related enough. Does that make sense?
Yes.
If they ask you a point blank question, you can't answer it, especially if you're less than, let's say, 60-40 in terms of certainty of the answer, or certainly less than 50-50, you're almost better off saying, I don't know.
Okay, makes sense.
Okay, great. Thank you.
Thank you.
Oh, sure. Melissa, trying to take you off of mute.
Hi.
Hi. So sorry you're having to put up with me for so long tonight. You're a generalist, is that right?
Yes.
Melissa?
Yes.
Okay. I'm sorry, my phone is like clicking out a little bit, as I mentioned, and I'm just afraid to redial in because we may all be talking to the air. Okay. Speaking of Class B, so hopefully you can see the list. Patient number 7 is a 41-year-old G3P1 at 37 weeks who's advanced maternal age. She has chronic hypertension. She's Class B diabetic. Baby was transverse. She had genetic counseling, was offered hypertension management, diabetic management in conjunction with endocrine, PO antihypertensives, baby aspirin, and external cephalic version. and the delivery was done by a partner at a later gestational age. So first of all, was your version successful?
Yes.
Okay. Do you recall the type of transverse presentation this baby was?
To be honest, not off the top of my head right this second. I do recall that she was transverse as opposed to frank or footling breech.
Okay. So what difference does it make what type of transverse presentation the baby is?
Well, that would make a difference as far as spine up versus spine down.
I'm sorry, as far as what?
Spine position of the fetal spine, spine up versus spine down.
Now, when you say up, you mean is up cephalic and down is toward the feet, or is up toward the anterior and down is posterior?
Sorry, anterior and posterior, so spine and anterior spine.
Okay. So what difference does it make which way the spine is if the baby's, laying across mom, so transverse?
In that way, in performing the version, it is a bit easier to, as far as my rotational maneuver, I feel like I'm describing more literally a forward somersault kind of roll with my positioning, as opposed to where the spine is posterior. There isn't with the back not being the most presenting part for my hands, not as it's more difficult in order to get the roll and movement around for me.
Well, first of all, were you successful with this version?
Yes.
Okay. So let's say you were unsuccessful and you were the one doing the delivery, does it make a difference whether it's back up or back down?
Yes.
These transverse, does it make a difference if it's transverse back up versus transverse back down if you're getting ready to do the delivery?
If I have back up, I can still make a low transverse uterine incision.
Okay. As opposed to back down?
Back down, I would either need to tee it or do a low vertical.
Why is that the case?
Because of what I have to be able to grab from.
So what would you do? Would you do a low vertical, or would you tee the incision?
Well, the reason why I would mention, I would hope if I'm able to correctly identify that in a situation where it is back down, then I would go with the low vertical.
Okay. So I see you gave this patient aspirin. Well, actually, before we go with aspirin, she's a class B diabetic. What does that mean?
So that's referring to White's classification of diabetes, and so a class B diabetic has had pre-existing gestational diabetes, I believe, usually for a time frame of, I want to say, less than 10 years, and does not have certain other chronic long-term, like it not affecting kidneys or heart function at this time.
So you said less than 10 years. So let's say she was, let's say the patient was let's say the patient's 27 and she was diagnosed at age 18. So she's had diabetes 9 years. Is she a class B?
If she was diagnosed as a type 2 diabetic, then I would say yes.
I'm sorry, then what?
Yes.
Okay, so if she were diagnosed as a type 2 diabetic at 18 and she's now 27, she's class B, right?
Yes, I believe so. Yes.
Okay. So, what are your criteria for recommending aspirin in pregnancy?
So, hypertensive disorders, so chronic hypertension, a history of preeclampsia, a history of, I want to say, renal disease.
I'm sorry, what disease?
Renal insufficiency.
Yeah, I'm sorry. The phone like clicks out sometimes. I just can't. The renal insufficiency. Okay. What else?
So then with having, those would be like some single risk factors when you have, also obesity, and pregestational diabetes. And then
So obesity, is obesity major or minor, or I'm sorry, major or moderate risk factor?
I believe that's categorized under moderate risk.
Okay.
And then a couple other factors, which if you have like more than one of, then you would want to consider. And some of those would include advanced maternal age. Oh, also going back, multifetal gestation would be a reason in itself for aspirin therapy. So for other risk factors, you could consider nulliparity, advanced maternal age, low socioeconomic status, African American race, and combinations of more than one of those factors would be for aspirin therapy that I would initiate at 12 weeks.
So you start your aspirin at 12 weeks?
Yes.
Okay. What's the latest you can start aspirin for it thought to have a beneficial effect?
I believe 12 to 16 is ideal, but I believe the latest with as far as a beneficial effect is, I believe they talk about 20 weeks.
Okay. All right. So last question. This patient was 41, obviously advanced maternal age. How does her age affect the gestational age at which you would recommend inducing this patient?
So if we're just taking into consideration her age in itself, I would recommend induction between prior to 40 weeks, so between 39 and 39 and 6.
Okay. Do you do any increased antenatal surveillance on your AMA patients their only risk is their age? So in other words, obviously this patient's hypertensive and diabetic. So of course you're going to do increased surveillance on her. But what about if someone's only risk is, let's say, being 40?
If her only risk is being 40 and she does not have any other criteria as far as we're talking about just antenatal testing, you could consider a third trimester growth.
I could do a lot of things, Melissa. What am I going to do? Or you could do a lot of things. I don't want to know what I'm going to do. I want to know what you're going to do.
I would get a third trimester growth scan and do twice the antenatal testing by 36 weeks and offer and recommend induction between 39 and 6 weeks.
I'm sorry. So you would get a third trimester growth scan. And what was the other thing you said you broke up?
Initiate twice weekly antenatal testing at 36 weeks and recommend induction between 39 and 6.
So what would your twice weekly assessment consist of? Would it NST, modified BPP, BPP? What are we talking here?
In my office, I do twice weekly NSTs.
Okay. Are there any recommendations that are consistent with that? In other words, is that recommended by in the literature or by ACOG?
I believe ACOG suggestions are they are not, although in NST as well as an AFI or a modified BPP are also suggested. There's ACOG endorses multiple forms as far as antenatal testing is concerned.
That's not what I'm asking. Does ACOG recommend doing increased antenatal surveillance on uncomplicated AMA patients?
I believe an uncomplicated AMA if they are 40 and above, no.
They do not recommend it. Is that I'm sorry, that's what you're saying?
Not anything additional besides, not anything additional.
When you say not anything additional to what?
Oh, I'm
understand
confused
what I'm
myself and you now.
What I'm asking is, does ACOG recommend antenatal surveillance on patients solely by virtue of them being advanced maternal age? So do they recommend third trimester NSTs or whatever, any increased antenatal surveillance just based on their age?
So I know they previously had, and I do know that they recently have come out with something in regards to that's not necessarily required in an uncomplicated AMA patient under the age of 40.
Okay, so why did you say you would do twice weekly, or why do you do twice weekly NSTs at 36 weeks then?
That is something that is, although it is my understanding that like a once weekly testing can be a valid approach. In my population, we have elected to go with twice weekly testing, partially due to our patient population and their compliance and concerns with, we have a large concern issue with some transportation and missed prenatal visits. And due to the trends there, we have elected to offer twice weekly testing, and we actually do have a high percentage of, I don't want to say no-show rate, but patients who are not completely compliant with twice weekly testing.
Right, but the question is why are you doing it if ACOG doesn't recommend it? Are you still with me?
Yes, is my understanding that I guess my answer is I would have to look into ACOG's current assessment as far as uncomplicated AMA.
Okay. Let's see. Okay, very good. Thank you. So let's go over it. So the case I gave you in terms of, or the scenario I gave you in terms of the diabetic who was diagnosed at age 18 and she's now 27, actually would be a class C, as in Charlie, diabetic. So you're right about the less than 10 years, but the patient has to be 20 or older when she's diagnosed and less than 10 years duration. So the scenario I gave you puts her in a C. The only reason, I'm not trying to beat you up over it. A lot of people don't use the classification on their list, but since you have put it on your list, you'll want to know the difference between the different gestational ages. Does that make sense?
Gotcha. Yes, yes.
I thought your aspirin list was quite good. Kudos to you. I think you pretty much hit nearly all of them. The recommendation is, 12 and starting between 12 and 16 weeks is certainly fine. The idea is to have it started by 28 weeks. So if you started beyond 28 weeks, not thought to have the same benefit or perhaps any benefit.
Okay.
So a little later than what was said. So your induction. So here's the thing. This is a little bit tricky, Melissa. There is no, to my knowledge, and again, someone feel free to throw it in the question box, or I'm going to put everybody's hand down in a second when we take the first round of questions. So someone feel free to correct me if your understanding is different. But age alone is not, I don't believe, is an indication for antenatal surveillance by itself. Now, more and more people nationally are doing antenatal surveillance, at least starting by 36 weeks on their AMA patients, and particularly if the patient is at least 40 years old. So here's kind of where the question comes up. So you're doing something that's not specifically recommended by ACOG. It's not saying that they recommend against it. It's just there is no recommendation that I'm aware of that suggests that you should do it. So the point is, in those situations, you have to explain why you're doing something that's not a recommendation or going against what ACOG says. So, a way to say this is, patients, when they get older, certainly they're, by age alone, they are at increased risk for intrauterine fetal death, particularly as their gestational age advances. So we do know, for example, a 40-year-old at 40 weeks has the risk equivalent of a 27-year-old at 41 and 5. So we do know that, again, statistically, they're at increased risk. And while there is no formal recommendation, out of an abundance of caution, I do recommend monitoring the patients starting at 36 weeks. Again, whether you're doing it weekly or twice weekly. The flip side question, though, could come back at you is, well, couldn't you falsely interpret, not your interpretation is false, but couldn't you have a false positive, for example, NST, and then act on it? And I think what you would need to explain is, well, look, if I did have that, abnormal NST, I would certainly bring the patient in for a biophysical profile, where I would expect less variation in terms of, false positive testing, if you will. So that's kind of the key thing. And again, you're talking about something that's non-invasive. So the only thing you really have to defend is the cost, which I would not bring up. And then the second thing is that you could falsely overreact to a result on the NST. Does that make sense? Melissa? Can you guys still hear me? Melissa got mad at me and hung up on me. Melissa, can you unmute yourself again?
How about, yes. Do you hear me now?
I can. I'm not sure what happened. Did you hear me or no?
It disconnected me, and then when it reconnected me, it wouldn't let me unmute myself. But yes,
Okay.
what you're saying makes sense.
Okay, great. Did you have any questions for me?
I think I got the gist. What were you going for with the if my version was transverse?
So I wasn't really trying to talk to you about your version as much as I was trying to talk to you about transverse back down needing a classical or at least a low vertical C-section.
Okay, gotcha.
That's what I was going for.
Okay.
Okay. Thank you.
Thank
All
you.
right, so I'm going to stop for my pleasure. Thank you. I'm going to stop for a second and go through the question box so that it's still fresh in folks' minds if they have questions. So if the mother has no vaccine side effects from MMRs, it's safe to assume that the theoretical risk of fetal infection has been eliminated in the mother if the mother becomes pregnant within those 30 days. So not necessarily. You know, people don't typically have side effects from any particular vaccine for a whole month, for example. But that doesn't mean that the live virus is not still in their system. But more importantly, they're going to take time to develop an immune response. I mean, you know that the patient, you know, you give her the shot, she may have a localized reaction, whatever. You know that she hasn't fully mounted an immune response in a matter of days. It's going to usually take weeks. So I'm not an immunologist, but that would be the answer I would suggest. So again, the recommendations, if you look on CDC, are for them to refrain from trying to conceive for a month. Okay, so Melissa, we good there. If you do something because it is a standardized recommendation across your hospital system, is it all right to answer that way? I.e., the umbrella organization that owns my group has an algorithm recommending twice weekly testing if the patient is older than 40. So kind of yes, you can say that. You can say, you know, look, in consultation with the maternal fetal specialists in our community, they recommend all patients that are 40 and older have, you know, antenatal surveillance because of the increased risk of intrauterine fetal death. As such, our practice, my practice or our practice complies with that, and we do get the twice weekly testing. Again, you know, you're saying you're basically just stating what you do and why you do it. They could come back and say to you, well, what if you moved to, you know, a hospital in the next city that didn't have that requirement? What would you do? In which case, you're kind of on your own there in terms of having to say what you would or wouldn't do and why. So, you know, you'll have to see whether you believe that it's appropriate. And again, guys, it's not a problem to deviate from what ACOG says. You just have to be able to explain and defend it. You know, ACOG makes recommendations. It's not the Bible, number one, although, you know, they are the guidelines. If you're deviating from the guidelines, you need to know what the guidelines are, and you need to have a reason why you're deviating. So, you know, again, I'm making this up, but let's say you practice in a really in an area where there's incredibly high substance abuse. You know, that may be a reason why all your patients at, let's say, 35 have weekly or twice weekly NSTs. You could say, well, that's not an uncomplicated delivery. Yeah, I get it, but we don't, you know, maybe not all the patients are upfront in terms of admitting their substance use. And again, I know you're doing probably urine tests for substance abuse, but I think you understand kind of where I'm going here, or at least hopefully you do. Okay, so would I consider HE4 as part of a common workup for tumor markers? Certainly can be part of a common workup with tumor markers. Not unreasonable because it's going to give you, you know, hopefully a little bit more precise information. The key thing about the tumor markers is, again, you got them in the event that the patient had a malignancy. You have a base from which to follow them, unless, again, you're practicing in a rural situation whereby if they were elevated, it might help triage the patient to an oncologist. Indications for outpatient fetal surveillance. Committee opinion states AMA over 35 is individualized. The newest obstetric care consensus that just came out this month, I have to admit I haven't seen it, said weekly NST is recommended for those who will deliver at age at or over the age of 40. Thank you, Daniela, for looking that up for us. So hopefully you guys caught that. Again, people that will be 40 or over at the time of delivery, and again, this came out with the obstetric care consensus this month. Weekly NST is recommended who will deliver it at or over 40. So thank you for pointing that out. And Serene, thank you for also pointing this out. It says, let's see, they suggest offering antenatal fetal surveillance for pregnant patients, again, with anticipated delivery at or over 40. So it says, so they're suggesting, okay, so the question then is, therefore, if they say suggest, and to your question, does ACOG recommend it? Would you say yes if I were taking the exam? So I would answer just like ACOG says. I would say, well, ACOG suggests it, and I happen to agree with it, so that's what I do. Or, you know, if you don't do it, you could say, well, you know, it's a suggestion, it's not an absolute recommendation. I don't think it's warranted because of whatever. So again, the suggest kind of gives you carte blanche to go with it in terms of saying that you do it. Okay, so that's it for the questions currently. So we will go back to taking volunteers. Thank you. Chioma, kind of take you off mute.
Hi, can you hear me?
Hi, I can hear you. Chioma, refresh my memory. Are you a generalist or specialist?
Generalist.
I'm sorry, are you there?
Yeah, generalist.
Okay, thank you. Give me a second. I will get your case list pulled up.
Okay.
Okay. Okay, so patient number 10 is a 53-year-old G1P1 with hot flushes. She has a history of a hysterectomy. You counseled her and provided medical management, and she had resolution of her symptoms. So tell me, what medical management did you provide?
In this case, I offered her, or I provided her with paroxetine.
Okay. So how did you counsel her regarding her options?
I counseled her that for management of hot flashes, there are lifestyle conservative options, as well as medical management with non-hormonal and hormonal options.
Okay. Does the lifestyle modifications really help?
They can be helpful, but typically I have encountered that the patients are already doing those. And so the ones that are seeing me for bothersome hot flashes have already tried them and typically want to initiate medication management.
So can you give me some examples of the lifestyle modifications that to which you're referring?
Sure. So dressing in layered clothing, utilizing the AC, dietary changes such as limiting use of caffeine, alcohol, chocolate, exercise may be beneficial as well. And those are
I'm sorry, what was
typically
the last one?
exercise.
Okay, thank you. Okay, so you said patients have already tried these often, and you mentioned medical management, including hormonal and non-hormonal. So how did you counsel this patient when you offered her hormonal medical management?
So regarding hormonal medical management, I counseled this patient that given she has had a hysterectomy, it would be with estrogen formulations. And I counseled her the route would be either an oral or a transdermal route.
Okay. So what did you tell her the risks and benefits of estrogen alone were?
In this patient, I counseled her that the benefit would be a reduction in her symptoms. As far as risks, they would include VTE. With prolonged use, there is a concern for cardiovascular disease.
I'm sorry, I'm sorry, if you could repeat that. You said with prolonged use, what about cardiovascular?
Cardiovascular disease.
Is increased or decreased with prolonged use?
Increased.
Okay.
And those would be the primary risks that I could think of with estrogen alone.
Okay, just to make sure I have it, you said reduction in symptoms is the benefit, and the risks are increased risk of VTE and increased risk of cardiovascular disease if they're on it for a prolonged period of time. Is that right?
Yes. The other benefit would be bone protection as well.
Okay. So two benefits and two risks, right?
Yes.
Okay. If you were going to give estrogen, you said you could give it orally or transdermally. Is there a particular way you would recommend it?
If the patient is able to tolerate, I would typically recommend a transdermal route.
Why?
Because with the transdermal route, there is a lower risk for VTE.
Why?
Because of the first pass effect. And so with the oral route, the metabolites that are generated when it's, I guess, metabolized through the liver can produce some thrombogenic factors. And so that leads to the increased risk of VTE.
I'm sorry, the liver can produce, you broke up there for a second.
The liver, so when the liver is metabolizing oral estrogen, it can produce thrombogenic factors that increase the risk of VTE.
Okay. If the patient had not had a hysterectomy, how would your counseling differ?
In that case, I would recommend endometrial protection. So the hormonal option would include progesterone as well.
Would that change the risks or benefits?
Yes, with the addition of progesterone, I would think about, or I would counsel the patient on the increased risk of breast cancer as well.
I'm sorry, you said the risk of breast cancer?
The risk of breast cancer. And I believe regarding colon cancer, I think that the hormonal replacement therapy can actually be protective. So that would be a benefit.
Okay, so you mentioned colon cancer reduction. Breast cancer, so what exactly would you tell the patient with respect to breast cancer?
I would counsel the patient that she is at increased risk of breast cancer with prolonged use. And so typically with these patients, I just counsel them that my general recommendation is starting at the lowest dose for the shortest duration possible.
Okay. So you mentioned paroxetine. Are there other non-hormonal alternatives?
Yes, paroxetine is the only FDA approved non-hormonal option, but other options include gabapentin and clonidine.
I'm sorry, what was the last one?
Clonidine.
Okay. What are side effects of paroxetine?
Side effects of paroxetine include some like GI discomfort, so sometimes constipation, sometimes nausea, vomiting. I would say overall it's well tolerated, but those are some of the risks. Drowsiness has been reported, and occasionally decreased libido possibly as well. But I would say overall well tolerated, and the risks are pretty low, particularly because it's a low dose.
Okay. All right, very good. Let's go over it. So nice job. The paroxetine, you mentioned decreased libido as a possibility. Sexual response or difficulty achieving orgasm is another risk. Patients can have headaches in addition to the nausea, vomiting, and GI side effects you talked about. But as you said, relatively well tolerated. Those numbers in terms of percentage of people who experience those adverse events are generally fairly low. Your lifestyle was fine. Lifestyle modifications are, I don't want to say they're falling out of favor. It's certainly easy enough to do, but generally speaking, not thought to be super effective in this case. But everything you mentioned was legitimate. Avoiding spicy foods is another one. Dressing in layers, again, trying to sleep in a cold place. I think you mentioned air conditioner, what have you. So your hormonal, for estrogen alone, benefits are going to be vasomotor symptom reduction and bone protection, which you said. Risks would be increased risk of DVT, which you also said. You also said that, though, that there's an increased risk in cardiovascular disease with prolonged use. That's not true. There is an increased risk in stroke for patients in their 70s, but that's about it. Heart-wise, there is no increased risk. You said transdermal would lower the VTE risk because it bypasses the first pass effect. That is correct. And ACOG wants us, if we're going to prescribe hormone replacement, to at least explain that to the patient and recommend the transdermal route as opposed to the oral route. Not saying you can't prescribe the oral route, but you just want to make your patients aware if they're not going to accept the transdermal route. You want to explain to them why you're suggesting it. Combination hormone replacement, you're right, it will also reduce colon cancer risk. There is a breast cancer risk. It's about 1 in 1,000 more cases. And it's, or, between 1 in 1,000 and 1 in 1,200. and that would be with 5 to 8 years use. Now, that was also with Premarin and medroxyprogesterone acetate. They've done some more recent studies looking at estrogen in conjunction with micronized progesterone, and they did not seem to see, again, in this most recent study I read, they did not seem to see an increased risk in breast cancer. I think where I would go with it is, for board purposes, I would mention that does seem to be an increased risk, but it's pretty rare, meaning 1 in 1,000, and only after 5 to 8 years use if you're using the same formulation. So there's still increased risk in stroke for patients in their 70s taking estrogen progesterone. In addition, if it's more than 10 years since the patient went through menopause, there would be an increase. And let's say you're starting her then. So she went through menopause at 50, you're starting her at 61 for some reason. She would also be at increased risk for cardiac events by starting, more than 10 years removed from menopause, again, on estrogen progesterone. So I think that's pretty much it. Any questions you have, Shimona?
Okay, so the cardiovascular risk, that is, that's with combined use you were mentioning, and then greater than 10 years.
Yes, that's with estrogen progesterone.
Okay, I got that confused. Okay, thank you.
Thank you. Nice job. Okay, very good. So let's take another volunteer. So, Gabrielle, were you volunteering?
Hello?
Yeah, hello. Are you volunteering?
Yeah, sure.
Okay, give me a second. Are you a generalist or specialist?
Generalist.
Okay. Give me just a second to pull up your list. Okay. I know we've probably talked about this on one of the other webinars, but I'm just curious because it caught my eye. Patient number 13 is a 64-year-old nulliparous patient with postmenopausal bleeding. She had an endometrial thickness of 34 millimeters, and the biopsy showed benign polyps. So you did a hysteroscopy polypectomy, and it showed EIN in the polyp. So you referred her to oncology. Why did you send her to oncology?
So we have like a robust gynecology oncologist that works with us. So it is in my preference to send him to gynecology oncology, especially with the diagnosis of EIN, where they're at increased risk for cancer or endometrial cancer at that. And with EIN, there's usually a 40% risk of endometrial cancer.
So do those patients automatically get a full staging? I don't mean the cancer patients, but I mean all EIN patients.
Not necessarily. It depends on the gynecology oncologist. But what I've seen so far is that they actually do like a sentinel lymph node biopsy.
But again, is that sentinel biopsy done with all the patients with EIN or only those that actually have cancer?
That would probably be preference for the GYN, but oncologist, but not necessarily that they need to do a lymph node biopsy unless cancer is diagnosed.
Okay, so again, I know you're not an oncologist, but if you sent a patient, if a patient is sent to oncology, or what are the criteria that would be recommended traditionally to do a staging procedure. So in other words, patient is found to have cancer. Under what circumstances would either a lymph node dissection occur or even a sentinel lymph node evaluation? What are the criteria?
So I think if it's invaded greater than 50% within the endometrium, and also if, staged, and then the grade was at a grade 2 or above.
Okay, so histologically, if it's grade 2 or above, so grade 2 or grade 3, and I'm sorry, what was the percentage that you mentioned?
More than 50% of myometrial invasion.
50?
Yes.
Okay, so when a staging procedure, well, first of all, how is endometrial cancer staged? Is it clinical or surgical?
Surgical.
Okay, and what specimens would be removed for full staging?
Uterus, cervix, fallopian tubes, ovaries, omentum, and para-aortic or pelvic lymph nodes.
Okay. So what risk factors did this patient have for having endometrial neoplasia or cancer?
For her age, that's for one, and that she had postmenopausal bleeding, a thickened endometrium. I would say that for that patient, and then if she was obese or had any underlying comorbidities like diabetes, hypertension, and then that would also increase her risk.
So do you know?
And she don't have any children, so she's a nullipart.
Okay. Do you know what ended up happening with this patient?
She did have staging procedure. Well, I think she did staging with sentinel lymph node.
Okay, because she did have cancer. I'm sorry, you broke up again.
I would have to look back. I'm not sure if she actually had the cancer. I'd have to.
But they did the sentinel nodes anyway.
Yes.
Okay. Okay, I think we'll stop here. So I think you did a really nice job. 40% chance that she's already got cancer with EIN, and about 30% chance it could progress to cancer if she doesn't already have it. Your staging information was good. Your criteria for lymph node sampling, at least traditionally, was good. Some oncologists do lymph node, sentinel lymph node dissection regardless, for basically any cancer. Here's one comment I would make to you, and this applies to everybody. You kind of want to know what happened to the patient, because it says referral to GYN oncology, which of course is appropriate. It can be appropriate, but they want to make sure that you close the referral loop. So in other words, they want to make sure that you kind of, I'm air quoting here since you can't see me, that you cared enough to follow up. So you don't need to know that, the patient underwent hysterectomy, and on day 2 she had an ileus, and day 5 she passed gas, and you don't need that level of detail, but you need to know she saw the oncologist, she did have cancer, she was a stage 1A, whatever she was, and her 5-year prognosis is X% or very good, or some hopeful quantification.
Yeah, okay.
So that would be for not just this patient, obviously, but anybody that's referred in that respect.
Okay.
Thanks, Gabrielle.
Thank you.
Jessica, you're next.
Great, thank you.
Are you a generalist or specialist?
I'm a generalist.
Okay. Let's see here. There you are. Okay. So thanks for hanging in with me, guys, for the 2 hours. Mucho apreciado. That's the extent of my Spanish, which was probably just butchered. I probably just butchered the whole language. But anyway, let's see what we got here. So patient number 9 is a 35-year-old G923 who had she's 38 and 6, had antiphospholipid antibody syndrome. She's rubella non-immune, had a precipitous delivery, and was continued on plaquenil and had an MMR vaccine. So how come she was tested for antiphospholipid?
She had many miscarriages with provider prior to coming to our office. She's a military spouse, and she was seen by a lot of other people prior to making a test for her very last pregnancy.
Okay, what are your criteria for doing an antiphospholipid syndrome evaluation?
I would do it if they had recurrent miscarriages in the first trimester, or a spontaneous miscarriage in the second or third trimester, or I guess spontaneous fetal loss in the second or third trimester.
So recurrent miscarriage in the first trimester, you said, or one in the second or third?
Yes.
Okay, are there any other criteria for doing an antiphospholipid evaluation?
Personal history of clot.
Okay.
Like if she reports history of unprovoked DVT or something, I would do it.
Okay. Anything else?
Not that I'm coming up with right now.
Okay, what blood tests would you get for an antiphospholipid evaluation?
I would get anticardiolipin antibody. I would get, we have a panel, lupus anticoagulant, and the anti-beta glycoprotein.
Okay, and so how come this patient was, or let me rephrase that, was this patient on insulin? Not insulin, on aspirin, excuse me.
She was on plaquenil, and she was, I don't recall if she was on aspirin or not. I would have to check.
So what is plaquenil?
Plaquenil is a medication that reduces the risk of blood clot in the setting of antiphospholipid antibody syndrome. And I believe it's also an anti-malarial.
Okay. Is it safe to use in pregnancy?
Yes.
Are you there?
Yes, it is.
Okay. Yeah, I'm sorry. What are the potential side effects of plaquenil?
No, I'm not sure. I would have to check.
What's the generic of plaquenil?
That's a very good question that I'm not sure. I would have to check.
Okay. Do you know what category medication it is?
I believe it's category C.
I'm sorry, you broke up again.
Category C, I believe.
Okay. All right. I think we will stop there if that's okay. So I have to confess, I am not a plaquenil expert, so I did look it up while I was asking you. According
Clearly,
to Dr. Google, it is. I'm sorry?
Clearly, I am not either.
According to Dr. Google, it is category D, although there have not been any associated birth defects associated with it. So go figure. It's an immunosuppressant, and it also will, as you mentioned, anti-parasitic. So it is used to treat malaria. It's hydroxychloroquine. Also good for COVID. Just kidding. Not true. So there you have it. I point this out, Jessica, because any medication that's on your list, unfortunately, you have to know about, even though you may well not have started this patient on the plaquenil. So if it's in writing on your list, you have to know about it. If it's something that you would treat a patient with, carbergoline, for example, and let's say you've never prescribed it in your life, knowing something about it, like, hey, I know I can use it for elevated prolactin or a pituitary adenoma, that's good. But if they say, well, what's the dose? And again, if it's not on your list, literally, well, I'd have to look it up. I don't prescribe it often. No big deal there. But the plaquenil would be a little bit bigger deal because, again, she's pregnant, she's on your list. Even if you didn't start her on it, you have to be sure it's compatible with pregnancy.
Did you say it was D like dog or B like boy?
D as in dog.
Interesting. Okay.
Again, just kind of Googled it. So
she did have an MFM consult that recommended continuation.
Yeah, here you should be able to see my screen now. So this is the nps.org, Australian prescriber. It says it's category D. There are now over 821 case reports of pregnancies with no increased risk in congenital malformations, miscarriage, or stillbirth. And here's another one from medicineandpregnancy.org. No evidence causes birth defects based on studies of around 750 women. So again, no increased risk, but, and this next one from NCBI at NIH says considered safe in pregnancy. But this other one is showing category D, so kind of go figure.
Interesting.
Anyway, yeah, I was kind of surprised. It's like category D, but there's no problem with it. That doesn't really make sense. Okay. So again, the take-home message, kind of almost independent of the plaquenil, is if it's on your list. So if this were continuation of Lamictal, let's say, because the patient had a seizure history or was bipolar, again, even though you probably didn't prescribe the Lamictal, you'll need to know about it. So that's kind of the take-home message there. So APS workup, you were correct. Anticardiolipin antibodies, lupus anticoagulant, anti-beta-2 glycoprotein 1 would be the 3 blood tests. And if one's positive, you'd repeat it in 12 weeks. It has to be positive twice, 12 weeks apart. The indications would be 3 losses less than 10 weeks or 1 greater than 10 weeks of a morphologically normal appearing fetus, arterial or venous blood clot, and you can use another clinical criteria of delivery less than 34 weeks for preeclampsia with severe features or significant uteroplacental insufficiency as another clinical criteria. Any questions, Jessica?
No, I think that was straightforward. I just need to learn my medications.
Great. Thanks for volunteering.
Thank you.
My pleasure. All right, guys, I'm going to pause for a second, and I want to make sure we get to the questions. So I am going to go to the questions here. Let's see. People could hear me. That's all good. Thank you for responding. Talked about the consensus, the suggestion. All right. So the next question, for patients with a uterus in menopause, can a Mirena be placed to protect the endometrium? It can be used to protect the endometrium. I don't want to say it's done super often, but you can use Mirena to protect the endometrium. Probably going to want to use something with a little bit, a progesterone IUD, maybe with a little bit lower dose progesterone. As you know, they tend to be smaller, and of course, as a postmenopausal uteri tend to also become smaller, so maybe a little bit easier to place a smaller progesterone-containing IUD. Is hospital pathology department, if your hospital pathology department reports endometrial results as hyperplasia rather than EIN, So it's on my case list as hyperplasia rather than EIN. Is that to my detriment? Probably going to fail and probably going to see you back next. No, I'm kidding. No, I would just, obviously you need to be familiar with the new nomenclature and of course why the new nomenclature was put into place. So just to review that briefly with you guys, the EIN versus complex or simple hyperplasia with atypia, the EIN was put in place to try to reduce the variable interpretation between simple and complex hyperplasia. As you may recall from your pathology rotations, the degree of glandular crowding dictates the whether something is hyperplastic and then whether it's simple or complex. So really, if you have tremendous glandular crowding with no really space between the glands, that's where you're starting to get to the complex hyperplasia. And then if the atypia, of course, is looking at the nuclei. So there was thought to be more reproducibility with the EIN and benign endometrial hyperplasia, again, because it's really with atypia or without atypia. So if it's without atypia, it's benign endometrial hyperplasia. If the increased gland to stroma ratio is such that they qualify as hyperplastic, and there's atypia of the nuclei, then they're just parked in the EIN category. So again, thought to be more reproducible, more standardization, which is why that nomenclature came out. But if your pathologist is still reporting it the other way, and you put that on your list, it's no big deal. You just need to know how to, quote unquote, translate it to the current nomenclature. Yeah, so that, I mean, where that comes into play also, and some of you may have it if you have premenopausal patients, so basically, you know, younger menstruating or reproductive age patients, and you got an ultrasound, let's say for abnormal uterine bleeding, and your radiologist reported as thickened endometrium. So there is no such thing as thickened endometrium in a non-menopausal patient. So people always panic when I ask them what's a thickened endometrium when I'm doing private mock orals with them, and they panic. They're like, well, you know, because let's say she's 40 years old. So they might say, well, you know, greater than 15 millimeters or greater than this or greater than that. Well, there is no cutoff for a premenopausal patient. So then they start panicking like, well, it's on my list, it says thickened endometrium. And what I tell people is, look, I would just say that you were quoting the radiologist, but, you know, there really is no thickening in a patient who's not menopausal. In those instances, we're more concerned about heterogeneity versus homogeneity. So that's my tidbit as far as that goes. Okay, I think we probably have time for one more case. Jessica, your hand is up again. I'm trying to unmute you. Go ahead.
I'm sorry, I just didn't put it down.
Oh, okay. Never mind. Thanks. Kendra?
Hi.
Hi. Are you volunteering?
Sure. Yes.
Yes?
Yes.
Okay. And are you a generalist or specialist?
Generalist.
Okay. Give me 1 second here. Okay. Okay, so patient number 15 is a 17-year-old. Can you hear me?
Yes.
Okay, oh, I'm echoing, I guess. Patient number 15 is a 17-year-old nulliparous patient who was referred for heavy menstrual bleeding, frequent menses. She's virginal. We did a history and physical. Lab studies were performed by the referring provider, which did not show anemia or thyroid abnormalities. He was counseled on management options and ultimately placed on oral contraceptives. satisfactory response to oral contraceptives. So, is undiagnosed vaginal bleeding a contraindication to birth control pills?
No.
It's not?
In a virginal patient or in undiagnosed vaginal bleeding. In combined oral, yes.
Isn't that what this patient was placed on?
Yes, she was.
So how come you put her on birth control pills if you have undiagnosed vaginal bleeding?
Once coagulopathy was ruled out, the thought process was that in order to regulate her cycles due to her concern for more frequent menstrual cycles.
Understand, but again, we didn't know what the cause of her bleeding was. So why would you put her on birth control pills if undiagnosed vaginal bleeding is a contraindication?
In this age group, the thought process is that typically it's due to anovulatory cycles or an immature HPO axis.
Okay. Do you know how old she was when she first got her period?
I believe she was approximately 14.
Okay, I mean, do you expect that the pituitary axis would be mature by 17?
No.
No. So you're saying most 17-year-olds would still have an immature hypothalamic pituitary axis?
Yes.
Okay. So the workup for this patient included she'd had a thyroid test done by her referring doc. Any other tests that were done?
CBC and then the TSH.
CBC and TSH?
Yes.
What would be your criteria for doing a workup for a coagulopathy?
If this patient had a family history of coagulopathy, if she was known to have excessive bleeding during dental procedures, excessive nosebleeds spontaneously, those would be a starting point for me.
Any idea what percentage of patients would have, for example, like von Willebrand's, who are adolescents who have heavy bleeding?
I would quote.
Go ahead.
Oh, I would gather less than 10%.
Okay. What about if you have an adolescent patient who either is hospitalized or receives a blood transfusion? The better question is what percent of those folks end up having a coagulopathy?
Greater than or equal to 50%.
Okay. Okay. Just trying to think if there's anything else I want to ask you. I think that's probably it. I mean, that the big question is when to do the or what your evaluation should consist of, and when would you recommend doing an evaluation for possible coagulopathy. So, all right, ready to talk about it?
Let's.
All right, so indications for doing a workup for a coagulopathy certainly would include somebody who's hospitalized for the heavy bleeding and/or needs blood transfusion. So it's about a quarter of those patients will end up having some sort of coagulopathy, with von Willebrand's being the most common. So if you have a patient that's anemic, you would want to at least consider a PT-PTT, and you would consider a von Willebrand. The indications that you mentioned were good. Patient has family history, has excessive bleeding with dental procedure, easy bruising would be another one. So those would be reasons to get to do a von Willebrand's. I'm not. I mean, the immature HPA by age 17, I honestly can't say emphatically that you're wrong, but that does seem a little bit like a long time. Seems like most 17-year-olds are having normal cycles unless there's some other situation going on, like they're, PCOS or something like that. So, but again, I don't have anything definitive that I can produce and share that to you. It just seems a little bit late. So that was kind of a trick question I asked you about the birth control pills in terms of undiagnosed vaginal bleeding. So that is a contraindication to birth control pills, but in this age patient, not likely to see anything serious in terms of a cause of abnormal bleeding. By serious, I mean like, hyperplastic or malignancy. In fact, for these adolescent age patients, ultrasound is not even recommended necessarily to help in the diagnosis. Any questions, Kendra?
No, so with this patient, it was not necessarily that she was having heavy menstrual bleeding, it was more so frequent menstruation, whereby her menses was coming every 3 weeks and she wanted to regulate. So it was, I guess maybe it's kind of hard to place all of that into this case, but no questions.
Okay, because I mean, it says referral for heavy menstrual bleeding.
Right, which
and
is
again, yeah, no big deal. I mean, that's kind of like the irony, undiagnosed vaginal bleeding, but it's one of the main reasons we seem to use birth control pills. So, it's really more in conjunction with patients who, are at risk for having some reason for their heavy menstrual bleeding, either being, on the more concerning side, a precancerous or cancerous lesion, or perhaps even, on the less concerning, but still not necessarily going to be treated with birth control pills adequately, would be like a polyp or a fibroid. So benign, but may not overcome it with just the birth control pills by itself.
Okay.
Very good. Thanks for volunteering. All right, let's hit the questions one last time, guys. Let's see what we got. I'm going to put everybody's hand down, actually. I'm not sure if people still have their hand up. If you have a question that you didn't put in the chat box, please raise your hand and I will unmute you. Just going to get to this last question. We talked about the hyperplasia, so no other questions in the chat box. Shireen, trying to get you off mute.
No, I don't have a question. I don't know what happened.
Oh, well, your hand just popped up. Sorry.
Well, actually, okay, now that I see, can you repeat what you said about if you're going to treat for, or if you're going to look for coagulation disorders, 25% of patients you said would have von Willebrand's, or they would just have a coagulation disorder?
They would have a coagulopathy, with von Willebrand's being the most common. So those would be 25% of patients that either need to be hospitalized or receive transfusions would have a coagulopathy. And again, things we talked about, things to look for: family history, easy bruising, excessive bleeding with dental procedure or any other kind of surgery the patient may experience. Having to use 2 pads per hour, when she's bleeding heavily, could also be an indication to do the evaluation.
Okay, thank you.
But you would want to start with a PT-PTT, and again, strongly consider a von Willebrand's in those situations.
Okay, thank you.
Okay, thank you. Okay, so last call for questions, guys. Okay, hopefully it wasn't too mean to anybody tonight, and really, really appreciate y'all calling in and sticking on the phone, sticking on the webinar, I should say, for the full 2 hours. So you will have another host tomorrow night, and I will look forward to speaking with you all sometime in September. Good luck with your continued preparation. And again, thanks for my fact checkers who looked up some things while we were going through them. Have a great evening, and we'll talk to you all soon. Good night.